So I'm going to be talking about my experiences very much into the last decades that I've worked in across various sectors, advocating for safer use and harm reduction within it. So I've worked in prisons, in communities, I've worked in drug policy with the Home Office, worked with Transform as their co-CEO, and so we'll be doing a real exploration around how these policies have impacted those people that are in those services. People know what harm reduction is for a start? Do people know what it is? Yeah. So it refers to policies, programs, practices that aim to minimize negative health and social impact associated with drug use. It's policies and practices on human rights. It's where it's at around justice and sort of destigmatizing the users. I'm going to look at sort of traditional drug and alcohol services in the UK. And I've been working in them for a good 20 years now. And they really are shaped by whatever is happening politically, and that sort of impacts our funding and the people that then can access. So thinking about sort of the early 1980s where services were very much pushed around abstinent, you had to really push. If someone was coming into services, it was to get clean. You have to, I hate that using that word, but that's what they were saying. You have to get into recovery, you have to be free of drugs. It really polarized a lot of people that wanted to access those services, but actually had no chance, they weren't interested in reducing or were not ready to make changes. There was also a lot of high anxiety around the general population around AIDS and spread of HIV, and it really paved the way for the needle exchange programs. So 1987 was the first one in Peterborough, and what they found was public opinion at that point is that people were accessing the needle exchange, and because it was seen to be successful, it opened up loads of needle exchanges across the country. It also allowed other treatment things to be added to those needle exchanges, like methadone and sexual health and all sorts of other things, which was really fantastic. Exchanges today are really embedded in the treatment services, so they exist in pharmacies and in treatment services. A lot of different people access the needle exchange now. So in Bristol, we have a really high population of IV users. We probably have about 5,000 to 6,000 IV users in Bristol, a really high proportionate. And pre-COVID, the drug service there gave out over 1 million needles in a year. And over COVID, that dipped. But what we did see is a lot of people that are using the needle exchanges, especially in Bristol, are using it for steroid use. But also what we found sort of post-COVID is that people were intramuscular injecting ketamine in Bristol. And so there's a bit of an increase of individuals accessing needle exchange for those reasons. We also saw that in that kind of this period as well, part of the drug strategy was around getting drug education in early. So there was a drug education program in schools. They were absolutely useless. So I used to go into schools and speak to young people. Young people were really excited about what I was saying. It didn't make any difference at all. So they scrapped. There was no evidence in people changing around what you were saying. But what that did to me was that one of my first roles was working in Witney, which was David Cameron's constituency. That was pre him becoming Prime Minister. And so what I did at that point was take that opportunity that he wanted to support his constituency and the people that lived there. So he gave me money, £3,000, to put on the first drum and bass event. It was a sober event. He knew all about it. He gave me £3,000. So I put on this event, and 250 young people turned up. So that was 20 years ago. And then we kind of look at sort of the 90s rave culture in this period as well. And I've put in there Heaven, which was a gay club. And I used to go there and I used to give out condoms and lube and be known as the lube lady. And that was really great because it was my first kind of initiation into that kind of environment, which really helped later on in my years as I came to Bristol and looked at the kind of the dance scene and the night economy scene, which I'll go on to a bit later. So as the recovery kind of went out and, yes, that was great, but actually people are still using, they're still committing crime, there's not enough being done. What do we need to be doing? So the government was just like, no, actually, we're going to press down, we're going to have to be tougher on people, this is no good, people are still being, they're still using, they're causing a lot of money on the economy, and so in came the criminal justice era. I mean, this was really, really polarizing, really stigmatizing for individuals. And there was lots of different things that came about in this. There was the community orders that you get. So if you're arrested, you'll be tested on arrest. You could have an order which meant that you'd have to turn up for group. And if you didn't turn up for those groups, you'd then be sent to prison. And it was just a perpetual cycle, revolving door, the same people, and it wasn't really addressing any of their drug use at all. This strategy really kind of imposed the restrictions with other services. So you saw social services being really harsh on users as well, especially mothers. So at this time, you see a lot of mothers that were coming in who really needed the help. So general drug services, 70% are usually men that access services. They're really centered around males. And so women who had children were really further pushed away, not being able to access services with their children and get the help that they needed. So where are we today? Okay, so we've got this kind of recovery model going on. We know.
The mic's not picking you up.
Oh, okay, thank you. So we're in this recovery model, but also we know that a lot of it sits in public health. We know there's health inequalities going on, but we really have no money. We're at this age where we've just got so much pressure on services to perform. Shrinking budgets, competitive commissioning with local authorities, that's where the purse strings sit, and people are in and out of services. So people that have been there from the very start, who've been in treatment for 30, 40 years, are pretty much stuck in this service, in this way. They're institutionalized. Staff are already stressed, large caseloads, and I guess the only real thing that we've seen more recent times is the Dame Carroll review around more money in treatment services in order to kind of bring more people in and address what's going on. And that was probably the biggest cash injection we've seen since 1998, I would say. Alcohol is really only just on the agenda in drug treatment services. So if you had an alcohol problem pre-23, you really wouldn't know where to go. There wasn't really anything in drug services. And so we've only really just started to do that because we recognize nationally that alcohol is a problem. So who is the system really serving? It's currently really just serving those people that are already accessing those treatment services. And it's also those ones that have accessibility service. So when we think about that, it's people that have financial means to even to get to a service, are mobile. We know that a lot of drug users are older cohorts, so they come with comorbid health conditions, and therefore getting to a service is not always viable. Services are locations, they're only one hub, and therefore you might find that actually getting there, it's a long distance. There's lots of things that are an issue. Motivated to make change. This is quite a big one. So most services really want you to be walking through the door and be ready to make a change to your drug use. And that's when they'll be ready to work with you. However, if you're on pre-contemplation or actually you like using, that's still a bit of an issue. And so it's really hard to kind of think, well, where do you actually go? Who else is there for you? And again, if you've got services which are restricted through money and funding, there isn't really a lot of support out there. Who's it exclude? Those with mental ill health and trauma. And I think this is a really big one. If we're thinking about psychedelics in the space, we know that 1 in 4 adults have mental health across the UK. It's 118 billion each annually. That's impact on the economy through mental ill health. And what we see, and we'll go into it, is some of the research that we've done more recently in Bristol, the impacts of drug users and their mental health and how they've not been coming into services because there's nothing there for them. Black, minority and diverse groups, this has always been an issue. So majority of these groups do not access drug services. It's the stigma that's associated with them. In Bristol, even though we have a high population of diverse groups. We only have about 2 to 3% on the entire caseload accessing the services. It's really, really small. Women, alcohol use, we've talked about women. Unless the service already has something very particular for women, then women are really unlikely to access services. They've probably started out using with a male that already accesses services, and they become really, really vulnerable. Unless a service does something really unique by having something for women, then yes, they could access it, but it actually becomes really difficult. And recreational drug users. So again, we're not commissioned, a lot of places aren't commissioned for recreational drug users. It really sits outside the frame of opiate and heroin users. So really there isn't anything that most services really need to be doing for recreational drug users. Returning clients, so these are ones that just continue revolving door, been in the system for a long time, who just generally fall through the gaps and have been around for such a long time. Actually, what's happening if they're ever going to get in recovery? I just painted a really bleak view of drug services. I think I can because I've been around a long time. But then I came to Bristol, and Bristol was like, it's like Christmas came early for me. And for anyone that works in treatment services, Bristol was super, super exciting. There's so much going on. And I think as an ecosystem, Bristol has so many partnerships that want to work and do good for this community. And when you have that allyship, anything is really possible. So just thinking about some of the things that we've done. So ketamine research we did in 2008. We looked at the chronic use of ketamine on bladder. And that really coined the Bristol bladder. And yeah. But what that also did more sort of recent times is, especially with IM use, and referring back to this, when we worked with urology and we worked with the pain clinics, urology wasn't even speaking to pain clinics. And so that was a really interesting step for the hospitals to go, oh, right, we realise that people are coming round and round in the system. They have pain, but we're not recognising it's acute pain or chronic pain. So that was a really big step. Low dead space syringe research, again, really pivotal. So this allowed us to look at, actually, these type of syringes have no space when you draw back, which means there's less chance of having blood-borne viruses. And these particular syringes were actually used during COVID-19 for giving out the vaccinations. This was a really big piece of work. This is what we only supply now, is the low dead space syringes. Chlorhexidine wipes, so if you've got skin and soft tissue infections for injecting community, they can develop all sorts of abscesses and health conditions on their skins, and chlorhexidine wipes reduces any kind of blood-borne viruses. So we changed all of our needle exchange packs to then have those. Our users are really upset because most of the time they use the wipes to light them in order to create a flame. These ones you can't light. Alcohol detox is, again, what we find is having an open access somewhere central that people can attend, users can attend. You get to see and find out what the users are actually saying. And so, especially over COVID, that's when I stepped in to manage drug services, is during COVID-19 and everyone was put into hostels and hotels. People that were needing an alcohol detox, we started to detox them using alcohol. And that was a really fantastic, new, innovative way of how we could help them. Drug testing with Bath University. So this was, again, part of the ecosystem we had. We felt, myself and the late Maggie Telfer, we felt that we needed to get ahead of the game, especially with heroin and nicotines coming onto the market. And so we approached Wedanos originally. Wedanos were like, we don't want to do commercial testing. So we approached Bath University and we asked them, could you test heroin for us if we were to bring it to you? And the chief inspector of Avon in Somerset approached him because I had to obviously get legitimate reason to carry drugs in my car. And so he said to me, don't worry, Shoba, I'll give you a handwritten note and I'll drop it off tomorrow. And he did. So I drove up to, I mean, I kind of threw cannabis in there as well. I didn't tell him that bit. But I used to run up to the prison, collect all this spice. Again, spice had never been tested before. So I took all the spice samples and I collected all the heroin that they had picked up, and I drove to Bath and we would test it. And we would find a whole range of things in the drugs, and it was fantastic. So that really helped with the first drug testing that we had. So that really paved the way for us. The drug check-in in 2022, when we first had the license, Home Office came down and gave me and Fiona Measham an absolute grilling. It was Priti Patel that signs that license off. It's really weird. There's only one department under licensing, and it's firearms in there as well. So we have drug check-in, firearms, and all down to Priti Patel. And I remember them asking me, so in 2013, were you at Glastonbury? And I was like, oh no, was I? What was I doing? But they asked you all sorts of questions. The drug check-in then got really into difficulty on a local level. Our local council, were too afraid to go ahead with it. And so we had lots of issues around getting that authorisation from the local authorities. So we applied again, and the drug check-in at Bath really helped to move that across. But it was hard work. So now that is every last Saturday of every month for the next 12 months. Yeah. Then we had the rollout of glass pipes. Again, this is really great work. So Magdalena Harris, this was around mostly crack users and how we can sort of reduce health harms related to smoking. And we were the largest pilot site rolling out glass crack pipes. Again, even in Somerset, police were really up for it. Police Crime Commissioner, not so much. So I had to bring in Police Crime Commissioner and really get him on board. He was actually really excited about it, so that was great. But what that really showed us is that this group of people, crack users, had no real reason to come into drug services. There's nothing there for them, and suddenly we were having a piece of item that's exempt and saying, why don't you have this? Why don't you try this and see what it feels like? And what we learned throughout that process is that a lot of people were sitting on mental ill health, and there's nothing for them in drug treatment services, or in general services anyway. This one we did because we had the money from the Dame Carol, and this was to test for AA, which is a build-up of proteins in kidneys, which could then lead to dialysis. This was a great piece of work. It's not really been done in drug services, but we had additional money from the Dame Carol, which has allowed us to look at this. We were, we've got the ecosystem of hospitals and consultants who gave their time for free to just roll this out, because we've got such a big injecting community, and we were saving anywhere in the region of 40 to 70,000 per patient on the NHS. So what's the future? So Bristol has its own ecosystem. We know that. It's really great progressive thought leadership. Even in Somerset, again, really progressive as a force. In 2016, they were the first force to introduce the diversionary program for anyone that has possession of drugs, and as a first offence to attend a drug education program. And so you've got all these people around you that enable things to be really innovative. So the next step for psychedelics is just not seen in drug services. And we do in Bristol, we think about the drug check-in. We also have, we have a big nighttime economy. Woo! Nighttime economy. And so I want to introduce to you what my plan is for the future. And it will be my next hub on the high street in Bristol called Renaissance Bristol. My plan is to open this on a main street in Bristol. It will allow the community to come in with your voices of what goes on, your experiences with psychedelics. I will be having an array of workshops and education from different parts of the ecosystem in psychedelics, so medical, research, holistic. We already know that when you have an open access space and users come in, they really drive the research around using. And through that, that really changes policy. And we know that through the crack pipes, because that's now being taken to Parliament to make it not an exempt piece of equipment. So I want to leave that with you. It's a call for action for Bristol and for you guys to get involved. And we'll be looking at anyone that wants to be involved in that. But that's what it would look like.